would like to introduce Dr. Brad Britton. Dr. Britton, can you please tell our patients a little bit about you?
Hi, yes, I'm an Oklahoma native, born in Cordell, Oklahoma. I call Weatherford, Oklahoma home. Went to Oklahoma Christian for undergrad. I went to OU for medical school. Did my internship in internal medicine at Oxnard Hospital in New Orleans. I have been a board certified ophthalmologist since 1992 by the American Board of Ophthalmology.
So how many cataract surgeries would you say you do per year?
I usually do between 2,000 and 3,000 cataracts per year. I've again been practicing since '92.
Fantastic. Thank you, Dr. Britton. So what exactly is a cataract?
A cataract is nothing more than a clouding of the natural lens. When we're born, God gives us a clear lens, and through the years of UV light exposure, certain medical conditions, medications, it is very common for patients to begin developing cataracts in their 50s, and most patients usually have a visually significant cataract around the age of 65. Believe it or not, even sometimes children can develop cataracts, but our typical patient is somewhere between the age of 60 and 85.
Great. And where is the cataract located in the eye?
So the lens sits about 1/4 of an inch behind the front surface, which is the cornea. And the cornea is the clear window that you're looking through. The lens sits a little further back behind the iris and the pupil. The effects of UV light and, as I said before, some medical issues, certain medications, can cause the lens to begin to yellow and then become cloudy. The protein in the lens is kind of like an egg cooking. The white of the egg will go from clear to opaque as the molecular shape is changed by factors like UV light most typically. So when the cataract gets to a certain point, it's so yellow or clouded that glasses don't help enough, or you're having other issues with things like night driving, it doesn't help to change the lenses at a certain point, and so we opt to surgically remove the natural lens and replace it with an implant lens.
And then speaking of the cornea, does the cornea have anything to do with cataract surgery?
The cornea is very important. About 2/3 of our refraction happens through the tear film on the cornea. Another third or so of the prescription in your eye is by the lens that we remove when we remove a cataract. The cornea itself is very important because that's what's going to be left behind once we remove the lens. And if you have any astigmatism in your cornea, whether or not you have some in your current prescription, we sometimes have to deal with the astigmatism to give you your best uncorrected vision. You can still correct it with glasses or contacts, but most of the time patients can benefit from having the astigmatism corrected.
So there's different options for the lens implant when we take out the cataract. Tell me about a standard lens implant.
So when we do cataract surgery, we're going to make a very small incision in the edge of the cornea, a couple of them actually, and then we will make an opening in the front of the lens capsule and remove the natural lens using a combination of ultrasound energy, irrigation, and aspiration of the protein lens. We leave behind a structure called the capsular bag, which is your own tissue that was kind of the wrapper, if you will, around your natural lens, into which we can place the new implant of whatever type. The standard implant, covered by insurance, is a monofocal implant. So a standard lens doesn't correct astigmatism. The standard implant, you kind of have to decide, do you want to see well at distance? Do you want to see well at near? Most patients, the default is to give good distance vision. If you do a standard implant and both eyes are corrected for distance, you will need, at the very least, reading glasses. If you have much astigmatism, you'll probably still need a bifocal to see well at distance because of the astigmatism correction and the ability to read.
If someone does have that astigmatism, what can you do to help with that during surgery?
Astigmatism is a term we've probably all heard. It basically is a description of shape. I use the example, a football has astigmatism. It has a different curvature in one meridian than it does in the other. And so the side of a football has astigmatism. A basketball on the other hand, has no astigmatism. It's the same curvature in both axes of the eye. So when you have astigmatism, we can either reduce the astigmatism with incisions in the cornea, made either with a blade or with a laser, or a more common way these days is to use what we call a toric implant. The toric implant actually has the opposite curvature in the lens that offsets the curvature that's left behind in the cornea.
Fantastic. There are so many different lens options for our patients to choose. Besides the standard lens and that toric astigmatism lens, what are the other options?
So many patients use the opportunity when they have cataract surgery to try and be as free from glasses as they can be. And this usually can be accomplished one of two ways. One is with monovision. If you're familiar with that, it's usually something you've done with a contact lens, or in rare cases happens naturally, where one eye is in focus at near and one eye is focused at distance. Most patients do monovisions if they can tolerate it. If they haven't tried it in contacts, I don't recommend it, because about a third of patients adjust to monovision and love it right away. A third learn to tolerate it, but a third feel off balance with it and really can't get used to it. If your goal is to be as free from glasses as you can be, and you can't tolerate monovision, there are a couple of options: light adjustable lens, and there's also a multifocal implant, in which case you can be in focus from pretty much 16 inches to far distance vision. If you can tolerate monovision, the light adjustable lens is a great option, because a very small amount of disparity between the two eyes can accomplish the ability to see both distance and near. The light adjustable lens is unique in that the power of the lens can actually be changed after surgery. Sounds like science fiction, but we have a special laser that can correct up to 2 diopters of nearsightedness, farsightedness, and astigmatism to give you excellent vision. Patients who are good candidates for it, for example, those who've had previous refractive surgery, especially if they've done monovision before, that is a really good option. It can be adjusted inside the eye to correct it and fine-tune it up to 3 times to really nail the overall prescription. We decide if we need to adjust it or just simply lock it in, at which time your vision will be stable and corrected.
So, Dr. Britton, you mentioned multifocal lens implants. Can you tell us more about that?
Yes, multifocal lenses for patients who have the means to do it and who desire to be as free from glasses as they can be is probably the best way to accomplish it in most patients. There are some pros and cons. There are some issues that you need to be prepared for from a contrast sensitivity standpoint and from a night vision standpoint, in that the way the lens works is half of the light is focused at distance all the time. A quarter of the light is focused at intermediate, which is basically full arm's length all the time. And another quarter is focused where most patients would hold a book, which is about 16 inches away. Those parameters mean that from about 16 inches to infinity, you can see well. They come in versions that either correct astigmatism or not. There are certain conditions where you may not be a candidate for multifocal lenses. For example, if you have moderate to severe macular degeneration, you have severe glaucoma damage, or if you have swelling in the retina from an epiretinal membrane or diabetes. But for those who desire to be as free from glasses or contacts as they can be, about 94% of our patients will be free from needing glasses for most things. There are times for specific tasks like threading a needle or doing very detailed close work where you may need additional light or need some additional magnification. But for the most part, normal activities of daily living, the vast majority of patients are free from glasses. Most patients find that after we do the first eye in low light that they can see well at distance, even at night, but there may be a couple of halos around the light, and that's the part of the light that's focused intermediate and the part that's focused at near. It tends to be better after the second eye is done, and then it's usually something patients don't even notice after a few weeks. Most patients do extremely well. We've got the best lens technology we've ever had currently. There are a number of different types of multifocal lenses. Some are better suited for certain candidates than others. That's something we could discuss at the time of your exam as to which one I would recommend.
Tell us a little bit about the cataract surgery process and what to expect the day of surgery.
I tell patients to plan on being at the surgery center for 2 to 3 hours. There's a lot of paperwork. There's prep to get the eye dilated. There's a meeting with anesthesia where They will administer medication to relax your anxiety. Usually that's just done orally. In some cases that can be supplemented with IV. And then I'll talk to the patient before surgery, answer any last minute questions, and then meet you in the operating room. I'll put additional numbing medication in and talk you through the process. The patients are awake but usually don't remember it later. I will be narrating the case as I'm going. Just let you know anytime you may be aware of cool water or slight pressure. And usually the surgery only takes about 6 to 10 minutes. Then within 5 minutes of getting back to recovery, you'll be on your way home. So I tell patients plan to be at the surgery center for up to 3 hours for a 6 to 10 minute procedure.
Earlier, you mentioned the posterior capsule that holds the cataract and then holds the new lens implant. What is that common condition that happens to that capsule after surgery?
Pretty much everyone after cataract surgery will have the implant inside the capsular bag. As you heal, the capsular bag shrink wraps around the new implanted lens, holding it stable in the same place where the natural lens was. At some point, most patients within 2 or 3 years after surgery will require what we call a YAG laser capsulotomy. That's a simple procedure that can be done in the office with just a drop of anesthetic. It literally takes a couple of minutes to do. But I always tell patients, no matter what type of implant they have, that they will require a YAG laser at some point. Sometimes we will do the YAG laser as soon as 3 or 4 months after the surgery. Almost everybody eventually will need the YAG laser. It's covered by insurance. It's not a complication. It's just a consequence of healing.
Okay. We got to hear about, obviously, the great benefits of having cataract surgery with the improved vision and possibly not needing glasses or contacts so much. But with every surgery, there are risks. Can you go over the risks of cataract surgery?
Any surgery has the risk of bleeding, infection, inflammation. Those are the main things that we deal with. In cataract surgery, the most feared complication would be a bacterial infection inside the eye called endophthalmitis. In my hands, that's exceedingly rare, something on the order of 1 in 4 to 6,000 cases. Occasionally, retinal detachments can occur after cataract surgery. You can have a retinal detachment without even having surgery. When surgery goes smoothly, it doesn't increase the risk for retinal detachment, but that's something that can be repaired. The same goes for the infection itself, but usually that means a slower healing and in some cases less than full recovery because of the damage from something severe like a retinal detachment and infection. But the vast majority of patients in my hands don't have those sorts of complications. More common issues are temporary inflammation and swelling. Sometimes, especially if you stop the drops too soon, can have some rebound inflammation in the eye that can cause retinal swelling. And that can be treated, but it does delay the recovery of central vision. I always tell patients, continue your medications for a minimum of 4 weeks unless you're specifically told to stop them. There are also corneal issues that can sometimes increase the likelihood that you will have swelling in the cornea for a more prolonged period. For example, if you wait a long time and the cataract's extremely severe, there's more ultrasound energy exposure, and those patients tend to have a little more swelling in the cornea. Also, there are corneal conditions like Fuchs dystrophy, which can cause you to have a little slower recovery of the swelling in the cornea, and if we detect that prior to surgery, we'll let you know about that. But the vast majority of patients do well. A couple of other risks I need to mention are just the risks of anesthesia. Theoretically, patients can have a bad reaction to a medication. That's not something that is common in this procedure. We just do a local sedation and numbing with medication in the eye. For most patients, the anesthesia risks are lower with cataract surgery than most procedures.
So how does a patient choose which lens implant is best for them?
Usually after looking at a questionnaire as to what your goals are, whether it's more important to see close or distance, or if you really want to be as free from glasses as you can be, during your exam we can discuss that.
Perfect. Thank you.